Hey everybody, this is Eric with FlightBridgeED, and we're back with you for part 2 of our ventilator management series. This is going to be part 2 of 3, and let's recap real quick what we learned in part 1. We talked a little bit about cellular oxygenation, real briefly about the pathophysiology. Like I said in the part 1 podcast, I'm going to do an extensive series on oxygenation, pathophysiology, cellular metabolism, and kind of dive deep into that. I think that's a really important subject. But for purposes of this ventilator management series, I just kind of wanted to touch on some points because I think it's important. With regards to ventilator management, I did want to say that my approach to ventilator management has changed over the years, over the last 5 years. I know that this is a big jump for most everybody. I know it was for me. My initial experience with a ventilator was basically an auto vent. You set a tidal volume and a rate, and it gave that no matter what, and it wasn't very gentle for the patient. And as I progressed into my flight paramedic role with a couple of different companies, I was kind of forced to learn ventilator management, I found it to be quite enjoyable. I learned a lot, started getting a passion for it, and so through the last few years, I was able to take some classes, and I listened to a podcast one time, and I just loved the approach that this MD had laid out. His approach was based on the ARDS network. It made a lot of sense. I went on their website. It's called the ARDS Net. And I read some of their studies. I read the approach, and I really became a believer in it. And one of those studies, it was a prospective randomized multi-center trial with 3 different hospitals, and they compared tidal volumes of 12 mils per kilogram versus 6 mils per kilogram. Excuse me. With positive pressure ventilation, and they were comparing this to rule out and to see what the better approach was for acute lung injury ARDS. The hospitals that were involved are big, really big name hospitals: Johns Hopkins University, Vanderbilt Medical Center in Nashville, and Massachusetts General in Massachusetts. I read through these trials. I read through them. I applied the strategies to my patient care, and have really seen great things as it applies to my patient. So I've looked at different things. I've tried to read on different approaches, and really the ARDS network is the only one I can find that really has a proven track record of improving patient outcome. So I encourage you to look at that up, read on it, and so I just kind of wanted to throw that out there and explain why I approach ventilator management the way I do. It's because I believe in it. I believe that their approach is solid. So this podcast number 2, we're going to focus on the different modes of ventilation. We're going to talk about volume modes versus pressure modes, why we would use one over the other, and so we'll talk about 5 different modes of ventilation, and that'll kind of encompass this part 2. So the first mode of ventilation we're going to talk about is controlled mandatory ventilation, or CMV. This is a very easy, basic mode. It's not a mode I really care for because it can be a little bit brutal. It's only used really for apneic patients or patients that are comatose, paralyzed, where there's no indication that they're going to come out of their sedation, because it's going to give you a preset tidal volume, a preset rate. So you're going to set their tidal volume, you're going to set their rate, and it's going to give you a minute ventilation, which is great, guaranteed minute ventilation, but it's never going to allow the patient to take their own breath. It doesn't have a trigger on it, which, remember from our first podcast, a trigger is going to allow the patient to trigger their own breath. And you can imagine if a patient woke up and they were in this mode and they were trying to breathe, and the ventilator was slamming these breaths in, how uncomfortable that would be. So I'm not a big component for that. It may be used in the hospital setting more, but in EMS, I really don't see that there's a need for it. All right, the second mode of ventilation is assist control. This is a good mode of ventilation, and basically assist control is CMV, so controlled mandatory ventilation, with the addition of a trigger. All right, so i.e., it's assist control. You're going to set your preset tidal volume. You're going to set your respiratory rate, and you're going to have a guaranteed mandatory minute ventilation. It's great for patients with a normal respiratory drive, maybe that's got a muscle fatigue, so an asthma, COPD patient. It can be used for apneic patients as well. Great mode for those patients that we can adequately sedate and need respiratory arrest. So, good mode of ventilation. I have no real problems with it. I do think that there's a better mode of ventilation. If you're going to use this mode, we could use the next mode of ventilation. So the next mode of ventilation is going to be synchronized intermittent mandatory ventilation, or SIMV. This mode of ventilation has a few features to it that the other ones don't. You have the trigger, like you did with assist control, and you have what's called pressure support. If you remember in the first podcast, we talk about pressure support, which is an augmentation. It's only used when the patient initiates their own breath, and it helps augment that breath. It helps deliver that breath to the patient. So, obviously these patients are sick. They've got respiratory muscle fatigue, and anything we can do to help them wean off the ventilator or help them take their own breath, decrease that workload, is a positive thing as far as I'm concerned. So with this mode of ventilation, you're going to have a preset tidal volume. You're going to have a preset respiratory rate. You're going to have the trigger. And you're going to get that guaranteed minute ventilation like you would before. So you have the pressure support, and I always like to set a pressure support about 10 or 15 above my PEEP. Really don't remember where I learned that from. I don't know if that's a solid approach. I've never had a problem with it. I've never read that pressure support can be detrimental to our patient care or anything like that. I think it's a good thing. So that might just be my approach. So with this mode of ventilation, why are we going to use it? Well, anytime we have a patient that it could be apneic, it could be a weaning mode, in an ICU setting where you're trying to slowly wean the patient off. You can obviously use the pressure support to help that. Or if you have a patient that just needs respiratory muscle, has the respiratory muscle fatigue and needs a break, you can use this as well. And so if you had a patient that was paralyzed or sedated and they started coming out of their sedation, this ventilator mode is going to allow them to initiate their own breath. It's not going to allow the breath stacking. It's not going to, it's a great mode of ventilation. So I highly recommend using this mode of ventilation. If you had to pick between assist control or SIMV, SIMV is a great mode of ventilation. There obviously are advantages and disadvantages to all these modes, but in SIMV, an advantage again is going to be it's going to allow for spontaneous breathing. It's comfortable. It allows the patient to gradually increase worker breathing, and it decreases the chance of hyperventilation. So that breath stacking, right? And so the breath stacking leads to auto PEEP. Auto PEEP, increases our PaCO2. Increased PaCO2 over a long period of time is going to affect our pH. It's going to drop our pH. So you think that little things like that don't make a big deal, but really they do, especially over a long period. Disadvantages, obviously you can increase worker breathing too much, maybe too soon, too quick. If they have some pretty significant respiratory muscle failure or fatigue, that can obviously be detrimental. So, that's where you just got to treat your patients and look at the full history, know that they're in a situation where they maybe need to be sedated a little bit more. But I just think this mode gives you everything. It's got some safety features to it, so I think it's a great mode of ventilation. All right, so we talked about 3 modes of ventilation that were volume modes. So on those modes, the breath is set based on a tidal volume and a respiratory rate. The breath is delivered via a volume. But now we're going to talk about pressure control modes, or pressure control ventilation. And so there's a couple different modes of ventilation that we'll talk about. The first one, again, is pressure control ventilation with pressure support. And with this mode of ventilation, it's all based on compliance. Okay? So, like I talked about in the podcast number 1, your compliance and the volume that you put into the chest via the bronchioles into the lungs, compliance affects a lot of things. Increased compliance is going to increase pressure, and that's going to reduce tidal volume, all right? Or it's going to reduce the amount of volume delivered to the alveoli. So with this mode of ventilation, this mode of ventilation is used on patients with weak or baby lungs, okay? Very injured lungs, sick lungs. If you have a plateau pressure, we talked about plateau pressure in podcast number 1, and if you remember, I said plateau pressure is the most important reading that you have on your ventilator. It tells you the health of your alveoli, and if you have a prolonged plateau pressure of above 30, that can lead to ventilator lung-induced injury and ARDS or barotrauma and poor gas exchange. Multiple problems. So we want to always try to keep that plateau pressure low. And we talked about reducing our plateau pressure. To reduce our plateau pressure, we reduce our volume from whatever we started at on our tidal volume range, right? Tidal volume range is 4 to 8 mils per kilogram. So we talked about reducing that all the way down to 4 mils per kilogram. Well, what do you do if you reduce it down to 4 mils per kilogram and the plateau pressure is still above 30? One of the indications is to move to a pressure-driven mode that is based on compliance. All right, so you've looked at your patient, you've tried to fix the problem. Obviously, if it's a trauma situation and they have a tension pneumothorax, we can fix that. We can decompress their chest. But it's still a good idea to move them to a pressure control ventilation mode because it's based on compliance. It's never going to cause or overinflate that lung. It senses the compliance and delivers a pressure-regulated breath based on that compliance. So obviously, if the compliance drops, if it gets worse, it's not going to deliver the same amount of volume, if that makes sense. So you're never going to have the same minute ventilation. All right, and we talked about in podcast number 1 how minute ventilation is everything, and it truly is. So with this mode of ventilation, you really have to watch your patients. You have to watch to make sure that compliance is not getting worse. If the patient's presentation isn't worsening, that's causing a decreased compliance, which is going to cause a hypoventilation problem, right? If it's reducing the amount of volume delivered to the lungs, you're not going to have the same minute ventilation. So excellent mode of ventilation. It takes a little bit more expertise. It takes a little bit more thought. You're going to have to be watching your patients a little bit more closely. So how do we set this up? We're going to set our respiratory rate, and we're going to set our inspiratory pressure. The inspiratory pressure is going to give you a tidal volume. All right, so your tidal volume button in this mode of ventilation is not going to work. It's going to be probably whited out. It won't light up, and so you're going to set the tidal volume off of this pressure. All right, so how do we do that? So most ventilators default at a 20. So you push the inspiratory pressure button, and it's going to light up and say 20. That 20 is going to give you a desired tidal volume. And how do we look at that? Well, if you remember in podcast number 1, we talked about the exhale tidal volume, and that's labeled with a big V as in Victor, little t, little e, and that's going to tell you what's being exhaled out. All right, so if you're giving them 400 on your tidal volume and you're getting 350 back out, then that's appropriate. That's fine. Well, in this mode of ventilation, since this is based on compliance and we don't have a true tidal volume button and it's based on pressure, what you're going to do is you're going to titrate that inspiratory pressure to the desired tidal volume based on their exhaled tidal volume. All right, so let's talk about this again because I know this is a lot. Your exhale tidal volume is going to be where you want your tidal volume to be. So if we set our inspiratory pressure to 30, that 30 is going to give you a exhale tidal volume. And that's going to be different for every patient. Every patient has different lung compliance. So you're going to set a pressure at 30. You're going to wait a few seconds. You're going to see how the patient does with that. You're going to see what your exhale tidal volume is based on that pressure of 30. If the exhale tidal volume is what you decided you wanted your tidal volume to be, so let's say you decided you wanted your tidal volume at 500 and you're getting an exhale tidal volume of 480, then that's appropriate. So that's telling you that a pressure of 30 is giving you a tidal volume of 480, and that's close enough as far as I'm concerned. Now you have a starting point. Now, things you may see this get better, right? You're in a mode of ventilation now that is very gentle on the lungs. It's for that weak, sick lung, and it's going to be based on compliance, so it's going to be gentle. And if you're managing your patient with the ventilator appropriately, and you're oxygenating them well, and you're using the tools that I lay out in these podcasts, you may see an improvement in their compliance. And so with that, your exhale tidal volume may increase. So that same 30 pressure that gave you an exhale tidal volume of 480 in 15 minutes may give you an exhale tidal volume of 600. So you've got to be very careful to watch your patient and make sure that you stay in the range that you would set based on your ideal body weight and your initial tidal volume. And so how do we change that? We're going to decrease that inspiratory pressure. So if you see your exhale tidal volume climbing, you know that you got some improvement on your patient. Maybe you're oxygenating dependent lung fields that you weren't recruiting before. Remember when we talked about PEEP, your inspiratory phase, your inspiratory pressure, it recruits more alveoli. Okay, your PEEP maintains that recruitment. So if you're delivering a breath via pressure in a pressure control ventilation mode, and you recruit more alveoli, obviously that's going to translate to better oxygenation, and hopefully your lung compliance is going to improve, and you're going to see an improvement. So you just have to constantly watch this. This is again a more complex mode of ventilation, but it's really an excellent mode of ventilation. I really think that with real sick acute patients, you could probably put 7 out of 10 patients on this mode of ventilation. I don't really see that often. I only see flight crew members, clinicians that are real familiar with ventilator management using this mode, so I try to really push this mode because it's a mode that can kind of get you into trouble if you're not paying attention. All right, so let's recap that again. Your inspiratory pressure is going to give you a desired tidal volume. That's represented on your ventilator by an exhale tidal volume. This pressure is based on compliance, so your compliance can either decrease or increase. Your exhale tidal volume will then increase or decrease based on that, and you're going to have to constantly watch that inspiratory pressure, because just like we don't want a high plateau pressure, we don't want too high of tidal volumes. And if that inspiratory pressure gets to 30 and it increases that tidal volume to 600, and you have a tiny baby lung, that's going to be detrimental to our patients, so we don't want that. All right, so it's a constant balancing act. All right, so your plateau pressure. So we talked about why we changed to a pressure control ventilation. If you have a reoccurrent high plateau pressure that's unresolved based on your interventions or by reducing our tidal volume, you would switch to this mode. Okay, being that you're delivering this volume now via a pressure, you're not going to be able to check a plateau pressure anymore in this mode, because basically the inspiratory pressure that you set to get that desired tidal volume, that is the pressure that the alveoli are seeing. So that's essentially your plateau pressure, if you understand that. So if you want to check your plateau pressure, what you need to do is you need to go back to your SIMV mode of ventilation, and you need to check a plateau pressure on all ventilators. Those settings are saved. You shouldn't have to mess with any settings. Just switch back to SIMV, do an inspiratory hold, which is a half-second hold, and and check your plateau pressure. And most likely that plateau pressure will improve, and you can kind of gauge and see that your methods and your approach is helping your patient. This mode of ventilation is also the essential mode for all children. You always want to put children on a pressure-driven mode. There's a new mode of ventilation that I'm going to talk about. It's not really new to the medical industry, but it's called PRVC, Pressure Regulated Volume Control. We'll talk about that here in a second. But pressure control ventilation is the mode you would start out with all children as well. Because remember, children are very susceptible to barotrauma, and this mode of ventilation is going to be very gentle on those little baby lungs. It's going to be based on compliance. It's never going to overinflate. So it's excellent. It's also excellent for those really challenging patients like ARDS or a CHF patient that's got just tons and tons of fluid filled sacs. Their alveoli are just engorged with fluid. This mode of ventilation is excellent for that. So advantages to pressure control ventilation is it's going to really be excellent in trying to improve oxygenation for these challenging patients. We're going to use it for all children with high risk for barotrauma. It's excellent for decreasing plateau pressures. And any patient with possible compliance problems, it's excellent. So those COPD patients, those asthma patients, and like I said, you could place probably 7 out of 10 patients in this mode of ventilation. It's really excellent. Disadvantages: it can be uncomfortable. With any mode of ventilation, if you're not properly setting it up, if you don't give patients proper sedation, it can be uncomfortable. It can cause a risk for decreased venous return. Obviously, anytime you're delivering something pressure-wise, you're causing an increased pressure in the chest. You can obviously have a decreased venous return, kind of similar to a tension pneumothorax or really high PEEPs. But I honestly have never seen that. And then the other disadvantage that probably gets people into trouble is, remember, it does not give you a guaranteed minute ventilation. Your tidal volume is going to be dependent on your compliance, so that's always going to be changing. Okay, pressure regulated volume control ventilation, or PRVC. This is the new standard in children. It's a form of assist control ventilation. You have a ventilator-initiated controlled breath, so you're going to set a respiratory rate of, let's say, 20. You have a patient-initiated assist breath. So what that means is if you have a respiratory rate of set at 20, the ventilator will give 20 breaths per minute. But the patient can also initiate their own breath. And the ventilator knows that, and it will minus whatever breaths the patient takes from what the ventilator set breaths are. So if the patient takes 10 breaths, then the ventilator is going to give 10 breaths. So that's going to equal to 20. Basically, the way this works is it's a constant pressure applied throughout the inspiration cycle, like a pressure control ventilation, regardless of whether the breath is controlled or assisted. And so with this mode of ventilation, the patient can initiate their own breath, right? And so there's a constant pressure throughout the whole inspiration cycle. And that's a really good thing, because remember, the inspiratory phase of our breath that's being delivered recruits alveoli. So it's excellent for oxygenation. So because of that, it improves oxygenation because you have decelerating inspiratory flow patterns. And to kind of explain that, if you think about a respiratory cycle, you have an inspiratory phase and an expiratory phase. You have a delay in the middle. Being that there's a constant pressure that's being delivered, there's no delay there. So you have improved oxygenation. It's kind of like what I talked about in podcast number 1, where you have that inverse ID ratio, and we have a constant, a longer inspiratory phase. Obviously, if you have a constant pressure being pushed into the chest cavity, recruiting more alveoli, your oxygenation is going to be better. The way this mode works, though, it's pretty interesting. The ventilator adjusts the pressure from breath to breath. And it does that by monitoring each breath, and it compares it with the delivered tidal volume with the set tidal volume. So if your set tidal volume is set at 400, and remember this is going to be based off compliance as well, and it monitors the breath that's delivered, and it senses what the compliance is. The next breath is going to be different. The next breath is going to be delivered with a different pressure to try to maintain that same tidal volume. All right, so with PRVC, you're going to have improved oxygenation due to the constant pressure and decreased inspiratory flow patterns. The ventilator adjusts pressure based on patient's airway resistance and respiratory system compliance. And this is all because it's trying to deliver a set tidal volume. When the ventilator monitors each breath for tidal volume, if the tidal volume is too low, it increases the inspiratory pressure on the next breath. If it's too high, it increases the pressure. It measures this by examining the exhale tidal volume and compares it to the desired tidal volume. All right, so let's talk about this again. I'll see if I can kind of recap this. So the increased oxygenation is due to the consequence of a constant pressure. The ventilator adjusts pressure based on patient airway resistance, so that's based on the compliance, right? And it's sensing that. It's constantly looking at that. And it's trying to do this to deliver a preset tidal volume. The ventilator monitors each breath, all right? So it monitors each breath for tidal volume. If the desired tidal volume is too low, it increases the inspiratory pressure on the next breath to try to deliver that. So what that's saying is that if you have a set tidal volume of 400 and the ventilator delivers a breath, and because of compliance and airway resistance, it can only deliver a 300 tidal volume, the ventilator senses that, and it increases the pressure to try to maintain that or get that tidal volume up to where the preset tidal volume is. All right, so it does this by examining the exhale tidal volume and compares it to the desired tidal volume. Right? So when we think about exhale tidal volume versus tidal volume, remember that you're always wanting to be as close as you can. Whatever you put in, you should be getting back out. And so, if you're not getting back out what you put in, there's some type of a shunt. And we talked about shunts a little bit in podcast number 1. All right, so let's recap this again, because this is a complex mode. But basically, if you kind of see how this mode is, you do get a guaranteed minute ventilation. It's constant. The ventilator is constantly changing how it's delivering the breath based on compliance, and it's trying to achieve that minute ventilation that you set. All right, so the patient does the ventilator does a test breath. Is kind of how it works. All right, so imagine a test breath, kind of like a plateau pressure, an inspiratory hold. It measures the tidal volume, okay? It compares that tidal volume to the exhale tidal volume, all right? If it's more, then the pressure that was used to deliver that tidal volume is now decreased on the next breath, okay? If the ventilator compares the tidal volume and it is higher, or less than the preset tidal volume, the next breath, the ventilator is going to increase the pressure to deliver that volume, and vice versa. So it's a constant titrating to try to maintain that minute ventilation. So it's pretty neat. Again, this is the standard mode of ventilation for children. All right, so your duration of inspiration is determined by your respiratory rate and your ID ratio. Remember, we talked about your ID ratio and how important that is to use, and that you have your inspiratory time and your expiratory time. Remember, a longer inspiratory time is going to translate to improved oxygenation and better alveolar recruitment, right? But with that increased inspiratory phase, and you have that expiratory phase that's going to be decreased, you can have some air trapping, right? So you've got to kind of pick your poison. Are you trying to improve oxygenation with a tough patient that's very hypoxic, then this might be appropriate. If you have a patient that's already has a high PaCO2, has a lot of air trapping going on, then maybe this mode of ventilation isn't the best mode, or a longer inspiratory time might not be appropriate. So you got to really look at your patient, understand the history, what's been going on, before you implement these guidelines. All right, so your respiratory rate on this mode of ventilation is going to be set based on what you want. So your patient's spontaneous respiratory rate is less than set rate. Ventilator will give the appropriate additional breaths to maintain that. So again, if you have a rate set at 20 and their spontaneous rate is 10, the ventilator will give the additional 10 breaths, and vice versa. If you have a respiratory rate set on the ventilator at 20 and the patient's initiating 20 breaths on their own, then the ventilator is not going to deliver any breaths. Your tidal volume again is going to be set off of the range of 4 to 6 or 4 to 8 mils per kilogram. That's not going to change, and that's going to be off obviously ideal body weight. All right, so how do we set our pressure limits on this mode? The way to do it is, we know a plateau pressure is going to be never higher than 30. I shouldn't say that. We should always try to shoot for a plateau pressure below 30. All right, so a safe zone per this ventilation strategy is setting a pressure to deliver this tidal volume at about 35 to 40. You never want to go higher than that. So we want to set our pressure at 35 to 45 to deliver that tidal volume. So what the ventilator does is, you set that pressure at 35 to 40, the ventilator is never going to deliver a pressure up to 5 below that number. All right, so the ventilator is never going to deliver a pressure. If you set it at 30, it's never going to deliver a pressure at 25. If you set the upper pressure limit at 35, the ventilator is never going to deliver a pressure above 30, if you understand what I'm saying. And so that's kind of all based on the prejudice of plateau pressure and maintaining a plateau pressure below 30. Your IDE ratio is going to be about 1 to 2. And you can lengthen that exhalation process based on their etiology. If they're a COPD patient, asthma patient, a pediatric patient, we want to lengthen that out. And then obviously their PEEP is going to be set, based on your approach. But a PEEP of 5 to 10 is going to be appropriate. The thing I want to talk about this other upper pressure limit, and I know this can be kind of confusing. The important thing to note is that the upper pressure limit is based on the plateau pressure. All right, the ventilator will give a test breath and perform an inspiratory hold on its own. It doesn't. You don't have to do this for it. It then bases the pressure on what the plateau pressure is. It will adjust the pressure needed to deliver the desired tidal volume by increasing or decreasing the pressure. Plus or minus 3. All right, so the ventilator is in this mode is going to do a lot of things for you. You just kind of have to set it up, and it's all designed to eliminate the poor minute ventilation that you would see in pressure control ventilation, and it's used to eliminate the high plateau pressure. So it's constantly affecting change based on those parameters that you put in the ventilator. So advantages and disadvantages, I like to always talk about these. Advantages for this mode: it's excellent for children. You're going to get a guaranteed tidal volume and guaranteed respiratory rate. You have a very low risk for barotrauma because it's based on compliance. You have that decelerating flow pattern, provides for better oxygenation. Remember what that means is you have a constant pressure that's being delivered, so your respiratory cycle is it's not delayed. You don't have a inspiratory and an exhalation cycle per se like you would in the volume control modes. And you can better meet patients' inspiratory flow demands. So again, better recruitment of the alveoli, and so that's obviously excellent. Disadvantages: you can always potentially increase pressure too high in an attempt to maintain the desired tidal volume. So the ventilator can continue to increase that pressure to get that desired tidal volume. So that's again where you got to look at your patient. You got to understand that things are getting worse and try to fix the problem. All right, so you can have variable tidal volumes that can be higher or lower than the setting. So even though you're getting a pretty consistent minute ventilation, there is going to be a little bit of variability. You're going to have a little bit a difference. All right, so let's recap a few things. I want to kind of go back to this pressure. So always set your maximum delivered pressure limit to 5 centimeters of water below your set pressure limit. Okay. So remember, our high pressure limit is always going to be 35 to 40, and you're going to always deliver or set your delivered pressure limit at 5 below that. All right. So an example of that would be this. If your ventilator gives a control breath and senses a given pressure that's needed for a tidal volume, on the next breath the patient attempts to take a breath, the tidal volume will be higher than the desired setting. The ventilator will sense this, and on the next breath it's going to reduce that pressure to try to bring that tidal volume down. If the patient fails to take an initiated breath, on the next breath the delivered tidal volume will be lower than the desired tidal volume. So again, I hope it's not confusing. This is a kind of a complex mode, but if you can kind of picture, it's going to be a constant titration up or down pressure and volume to try to maintain that desired tidal volume that we're trying to achieve. All right, so CPAP. CPAP it's an excellent mode of ventilation. It's a form of PEEP. It's kind of interchangeable, and so the difference between CPAP and PEEP are just this: CPAP is going to recruit alveoli, and PEEP maintains that recruitment. Right. So CPAP is a constant pressure on the inspiratory phase, and so it's excellent for those patients that have decreased lung fields based on CHF, COPD. Their FRC, functional residual capacity, is maybe decreased. So CPAP is excellent for that. Maintains the patency of small airways. Obviously improves gas exchange by having that prolonged inspiratory phase. Reduces the workload of breathing. So it's an excellent mode of ventilation. Excellent for those patients that are maybe you don't want to intubate, you don't want them on the ventilator, you want to try something different. Excellent mode. So remember, this is a non-invasive mode of ventilation. So our goals for CPAP are obviously we're trying to increase our PaO2, we're trying to increase tissue oxygenation, we're trying to see improvement in our SATs, we're trying to decrease our work of breathing, and we're trying to decrease the need for intubation. Obviously, we don't want to place these patients on the ventilator. That's not optimal. Every time we put a tube in somebody, whether it be orally or peripherally or a catheter, a Foley catheter, anything like that, we've increased the incidence of infection. So anytime we can do that or alleviate that, that's better for our patient. So indications: CHF, pulmonary edema. I remember 10 years ago when we started doing CPAP, most protocols, COPD patients, it was kind of contraindicated, but now That's a normal thing. Pneumonia, obviously acute respiratory distress of unknown etiology, cardiogenic shock with pulmonary edema. With that, you need to be a little careful. If they're in profound hemodynamic shock, it might not be the best option. You might need to go another route, but obviously just look at every patient. So CPAP in the helicopter realm, or the when we talk about fixed wing flight, here's my thing on that. You need to know your aircraft's capabilities. You need to be able to do the math and figure out how long you're going to have with your oxygen reserves. Are you going to need to titrate your FiO2 down to a range where you're not going to run out of oxygen? If you have an hour flight and you have 1800 psi main bottle in your helicopter, you're not going to make it to your receiving facility. I can tell you that right now. So if that's all you have on board, even if you had another small pony bottle with 1800 psi and your patient needed that high FiO2, you're not going to make it. So that's where you need to really look at your patient. It's always good to get a blood gas. It's good to see where they're at, right? So why would we want to get a blood gas in this situation? Well, if you check their blood gas and their PO2 is very low, right? We talked a little bit about that oxalate hemoglobin dissociation curve and that left shift. So if their PO2 is 50, they might not do very well when you titrate that FiO2 down. They may need high FiO2. And if you have an hour flight and you have, a limited amount of oxygen, you're not going to make it. Remember, CPAP goes through a lot of oxygen very quickly. So in this circumstance, you may need to RSI the patient and put them on the ventilator and manage them that way. So always think about that. Now, in other helicopters, if you're using liquid oxygen, you have 8 times the amount of oxygen per liter. So if you have 3 liters of liquid oxygen, you have, you have a lot of oxygen. Let's just put it that way. You have, 4 or 5 times the amount that you would have in compressed gas. So in that situation, then you're going to be fine. So just know your capabilities of your aircraft, know what kind of oxygen you're carrying, and just be cognizant of that, because that can kind of get you into trouble. All right, so BiPAP is another mode of non-invasive ventilation, and the big thing with BiPAP is, a lot of people say, or it's taught that BiPAP is a little bit more comfortable for the patients. And let's go back to our CPAP. So how do we set CPAP up? Basically, what you're doing is you're setting the pressure support. We talked about pressure support being an augmentation, and so you're setting an inspiratory pressure, and that pressure is going to be delivered to the patient. So maybe start out at 8, see how the patient does with that. Make sure the patient has a good mask seal. Let's talk about your patient needs to be conscious, alert. He needs to be able to maintain their own airway. They don't need to not be real fatigued. You don't want them to all of a sudden go unconscious or apneic, because the patient has to spontaneously breathe for the ventilator to work appropriately. Most CPAPs, BiPAP modes on ventilators have safety features that are apnea features, where if the ventilator senses apnea, you can set it 15 seconds, 30 seconds, 60 seconds. If it senses that and that time period has elapsed, you're going to set a tidal volume and a respiratory rate, and it's going to take over and start initiating ventilations for you. I'm always a big component of never go down that road, never get to that situation. If you feel like your patient is that sick, that unstable, they're not going to be able to maintain that throughout the flight, you need to be thinking about doing something else, RSIing them and managing their airway, the ventilator. Remember, when you're in a helicopter, your assessment skills are way different than they were on an ambulance or in the hospital setting. You have a helmet on. It may be dark in there. They're wrapped up in a blanket. If they're, depending on the aircraft you're in, they may be facing away from you. And so assessing them is a lot more difficult. So again, put yourself in a situation where you can properly manage your patients. That's going to provide good patient outcome. Don't get yourself into trouble. So with a BiPAP mode, BiPAP gives you two different levels of ventilation. It gives you the inspiratory phase based off of your pressure support, but it also gives you the expiratory phase, which is elicited by setting a PEEP. So in a patient in BiPAP, you would set an inspiratory pressure of, let's say, 10, and you'd set a PEEP of 5. And so when the patient goes to exhale, what the ventilator senses, it drops the pressure down to that 5, and the patient is able to exhale a little bit more efficiently. It's a little bit more comfortable, a little bit easier for the patient. So that's the big difference between CPAP and BiPAP. So again, you're going to set your FiO2 based on your ABGs. Try to get an ABG. Some facilities, some small facilities, they don't do very many ABGs. It may be difficult for you to get an ABG from them. You don't want to prolong transport, don't prolong patient care. But if it's going to take 5 minutes, if you go in and you are very nice and respectful and you ask them to draw an ABG, they may do it. I've had a lot of success asking that, and you need to ask it initially when you get there. And it's always important with these CPAP or BiPAP patients, give them a little sedation. Don't give them something to knock the respiratory drive down, but give them a milligram of Ativan, or give them, a milligram of Versed. Just enough to just make them comfortable, because some patients don't do very well with that mask on them. So, kind of recap, we went over, volume control modes, we went over CMV, we went over assist control, we went over SIMV, and we went over kind of the advantages and disadvantages to those volume modes. Then we moved in and we talked about our pressure-driven modes, and we talked about indications on why to use them, and kind of the more complex aspects of those modes, and how they can affect your patient in a positive way. I'm a big believer on the volume modes, but I have no problem switching to a pressure mode once I see a few little trends happening with my patient, and I've seen some great things happen by switching to those volume modes. So I really encourage you to study those. If the PRVC mode of ventilation was confusing to you, please let me know. Send me an email. Maybe I'll do a blog on that, and we'll talk about that, and we'll try to explain it in more depth. I know it was a lot, but so this is everything as far as those modes of ventilation. There are other modes of ventilation out there, but as far as EMS goes, these are the main ones that you're going to deal with. So this is going to be the end of podcast number 2. We'll see you shortly. I'll talk to you shortly, and we'll talk about podcast number 3. It's basically putting everything together and talking about a few scenarios. So thank you for joining me. Let me know goods and bads, things that I can change. This is all for you guys, and I'm really enjoying doing this. So I'd love to hear your feedback. I'll talk to you soon.